about scoring systems because, there's always going to be a scoring system out there, isn't there, for a lot of these things. Are they useful? What are they? Do you use them in practice?
The one I use I use a thing called a heart score.
Yeah, okay, I've heard of that come out. Yeah, it's recent, isn't it?
It's quite recent, it's quite new. It's in the NICE guidelines, which is why it's been incorporated in our practice. I'm not a massive fan of the heart score. Oh. It's a little bit risk averse, in my opinion. I find I end up admitting a lot of patients under medicine who I don't really think have had an MI or a significant cardiac event, but they are elderly. They've had a previous MI or something like that.
The computer says yes.
Basically, the computer says yes.
Yeah.
And that's always the problem with scoring systems anyway. And it's one of those, your consultants and things and your senior doctors may well override these scoring systems, and that's actually appropriate. There's lots of good evidence that actually senior clinicians do better than scoring systems. All these things are great, but senior clinicians are better.
And that's good, isn't it? Because actually AI is coming. And it's coming for all our jobs. And so basically, we don't want to get taken over by something that can go beep, boop, beep, boop, boop. You don't have a heart attack.
No.
Beep, boop, beep, boop, beep. You do have a heart attack. In exactly that way.
Exactly. And if you do, exactly. I mean, there's no point doctors existing if you just use algorithms. If you can just input all the data into an algorithm and output something, then why do we exist at all?
I think I read that on your CV. I think it just said Matt Young, not just another clinical decision user.
Exactly. The other score I should mention is GRACE. GRACE it's a global registry of acute coronary events. Basically, it's called the cardiologists will use to help risk stratify patients who require angiography. And that's generally used in NSTEMIs and unstable angina rather than your STEMIs. But it's quite a useful scoring system that you might see used on your cardiology placements. And TIMI is the other one that's thrown around. That's the thrombolysis and MI score. It's a slightly less thorough version of GRACE, but it's often used in practice quite a lot as well.
Okay, so we've talked about presentations and investigations. I guess now it's about management. And when we're managing somebody who we highly suspect or we have shown is having an acute coronary syndrome, the objectives really is to reduce myocardial demand and increase coronary blood flow. You don't need to hear this anymore, but you're going to. You need to do an ABCDE approach on these patients. What are you going to find? Well, you might find quite a lot of stuff, but really you're correcting as you find it. You might find some. I mean, you could have airway issues, but that's pretty far down the line, isn't it? Breathing, there may be an increased respiratory rate. It would be good to listen to the chest to check if there's any concurrent heart failure. In terms of reduced saturations, really, we want to just be giving oxygen enough to get the saturations in and around 94 to 98%. These patients, although critically unwell, do not need high flow oxygen the entire time, and there's some thought processes around that. If you look at the AVOID trial, which we'll include in the show notes, there is a increase in oxygen-free radicals, essentially, which can cause further myocardial damage. So actually you worsen their patient outcome if you give high flow. So nasal specs usually often used if there's a bit of hypoxia, and just titrating to effect. Circulation-wise is going to be where you're going to have your main input. So banging on an ECG, making sure that the blood pressure is within normal ranges, being careful with administration of nitrates and opiates, but clearly really, really important. Giving fluids as and when you need and drawing off bloods. Usually these patients will need a singular large bore or two wide bore cannulas if they're critically unwell. And so C is where you're going to be doing most of your input. Now, we do have a treatment, a sort of acronym, don't we, that we band about. So Matt, do you want to kind of talk about that a bit more?
Yeah, so we talk about MONA quite a lot. Morphine, oxygen, nitrates and aspirin.
Yeah.
Morphine's quite useful for pain and also to reduce anxiety and things. Oxygen, which we mentioned, you don't want to over-oxygenate these patients. Nitrates, always pretty good at reducing your preload essentially, so it works more on the reducing myocardial oxygen demand aspect of your protocols rather than lots of people think sort of dilates your coronary vessels. It does a little bit, but not as much as you think. It's more of a venous dilator, so it's more about reducing preload. Just be cautious if you've got a patient with a right ventricle infarct, because as we mentioned earlier, that's more of a preload issue. If you're not, if you're filling there properly because of the infarct, you don't want to then worsen that patient's preload. That will lead to a worse outcome.
Yeah. So quite commonly, I actually try and quickly grab a 12 lead before I'm giving these nitrates.
Yeah,
so if I
I
can get bang, 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 print it out. Right, it's not an inferior with right ventricular. Right, we can So I will often do that, although I know that's not specific guidelines.
No, but that's safe, and that's probably what we should be doing. You're welcome. And the aspirin. So really want to give a loading dose, 300 milligrams. Very good antiplatelet is aspirin. Cheap, easy to get. Paramedics have it. Most GP surgeries have it. We obviously have it in hospital.
Patients have it.
Patients have it a lot
you
of
can
the time
just,
as well.
You can just give them a quadruple dose of their 75.
Yeah. Often it's something that 111 will say.
Yeah.
Take 4 of your aspirins before the paramedics get there, and that's certainly going to save lives. And that's our nice little acronym. So if you can get that in your head and remember it, great. Once you're in hospital, once we're going down that ACS route, you're going to be wanting to add in a second antiplatelet. Now, locally in Cornwall, ticagrelor is key. Generally, though, in the rest of the UK, it's clopidogrel.
Yeah, clopidogrel.
And evidence-wise, basically the same, to be perfectly honest. There's slightly increased bleeding risk with ticagrelor and slightly better 6-month, or I think it might be 12-month outcomes with ticagrelor.
Okay.
But they're largely equivalent, and certainly nationally and internationally, to be fair, a lot of the Americans are still on clopidogrel. It probably doesn't matter, but certainly a second antiplatelet is what you want. Prasugrel is another one that will be banded about. It just depends where you're working, what your local guidelines say. Other medications to consider, so fondaparinux, which is a heparin essentially. It helps prevent that fibrin clot from forming. It's used when patients aren't going to go for primary PCI. You don't want to give it if they are going to go for a primary PCI because it will increase the bleeding risk when they put the art line in. Beta blockers. Yep. Now, acutely, I don't tend to start beta blockers because because they're negatively inotropic, and one of the key sort of complications from MIs is pulmonary edema. So we don't want to reduce inotropic ability of the heart unless we're pretty certain there's no heart failure.
And that's interesting because there was thoughts about rolling out beta blockers for pre-hospital use. I think it's done in certain European countries, but perhaps that's what's actually stopping us from doing that.
Yeah.
So there are these complications.
It's one of those things, things you get worried about would be pulmonary edema, hypertension, and certainly bradycardia or arrhythmias. And actually, I'm not sure the benefits of reducing the contractility of the heart, reducing that myocardial oxygen demand, outweigh the risks of those things. Other meds while we're on there, just to mention, ACE inhibitors as well, more useful for your ongoing management, so that's something that might be started on the ward. It helps to reduce any cardiac remodelling that occurs post-MI and also helps control hypertension and things. And one thing we do need to mention as well is the glycoprotein 2B, 3A receptor inhibitors. Now, these are reasonably new drugs coming out in the past 8 to 10 years or so. Generally started by cardiologists, so you don't need to know too much about them. They're generally used in your high-risk end-STEMI patients and in the patients in the cath lab who have STEMIs. So it's not something I typically start. But otherwise, in terms of other interventions, Joe, we talked about the meds. What interventions are we leaning towards?
Yeah, so I mean, the gold standard treatment for STEMI is PPCI. So it's primary percutaneous coronary intervention. And really, this is stent inserted either via femoral or via radial up into the coronary artery. It's pretty amazing surgery if you actually watch it. I've been lucky enough to take patients in pre-hospitally and get to watch it, which is always the best. And essentially it's removal, physical removal of the clot. NICE recommend PPCI if the presentation's within 12 hours. And when I remember when this changed in pre-hospital guidelines, and it was essentially what we were aiming for was what they call door to balloon time of under 90 minutes. Yeah. And so basically the only time that patients are pre-hospitally thrombolised now is in those remote parts where you can't get a door to balloon time of 90 minutes. Yeah. And so really that encompasses pretty much everyone because it's such a gold standard. It's a relatively safe surgery. And the PPCI labs are absolutely specialist in it, and so we actually now just transfer straight to the PPCI labs, and it's really, really effective. I've seen patients come in cardiac arrest on a Lucas, and I've taken patients in cardiac arrest on a Lucas, and they've had PPCI, and they've got really good neurological outcome. So it really is fantastic. Thrombolysis does still happen, as I say, in remote areas. So if we're thinking, Scotland, remote parts of Wales, Ireland, Scilly Islands, Isle of Man, Shetland Islands,
other islands, all the islands, Ireland.
Rural places basically. Matt, what else do we go for if we haven't if we've undergone primary PPCI or if we're not going to go down that pathway?
So we're going to be employing our GRACE score again. So if you've got a patient NSTEMIs or your unstable anginas, your non-STEMI patients, you're going to be teeing up the benefits and risks of doing angiography.
Yeah.
You'll often be consented for angiography plus minus PCI, so plus minus a stent.
Yeah, whilst they're doing it.
Diagnostic and can be interventional as well, which is quite good.
Yeah.
Sometimes though, if you've got sort of double or triple vessel disease, which isn't amenable to stenting, then coronary artery bypass grafting, so cardiac surgery, CABG, is going to be your option. And cardiologists will often sort of stop an angiogram and refer the patient for consideration for CABG. Other management things? Any other little snippets we need to put in there?
Oh yeah, well, I mean, in thinking in certainly in primary care perspectives, when we see a patient who's had an MI, we will often then talk about your kind of secondary prevention. So you'll see these patients usually discharged on a load of medications, and what we'll actually talk about with them is lifestyle.
Yeah.
So clearly, smoking cessation at any point in your life is really good. Good management of hypertension, good management of diabetes, and cardiac rehabilitation is often something that we'll do. But thinking about exercise, your diet, trying not to have any more MIs, encouraging your family not to have any MIs, all of this.
Positive mental thing. Yeah. I will not have another MI.
Positive psychology, who knows? We could do a study on that.
Maybe we should.
But yeah, so those are the different kind of dietary lifestyle advice is what we call it for ongoing management. Okay, so we've had a quick run through of that, Matt. In ACS, it's been a bit of a whistle stop. It's such a big topic.
It's a huge topic,
isn't it? And we could talk about it for ages because I think we're both quite passionate about cardiac presentations, aren't we? So that and pretty much that and sore throat. So why don't you run through what we've gone through?
All of it.
Yeah.
Okay. I think a key sort of take home message is remember that ACS encompasses several conditions: unstable angina, non-ST elevation MI, ST elevation MI. Really, the key issue is the mismatch between myocardial oxygen demand and myocardial oxygen supply or coronary blood flow. And your investigations and management are looking to see if you can marry those two up, essentially. ECG is key, so make sure you get your ECG early. Remember that typical chest pain, in inverted commas, often isn't a cardinal presenting feature in acute coronary syndrome. So have a broad net if you're seeing patients sweating, vomiting, short of breath, especially in the diabetics and the elderly. And just be aware of some of the key complications that we've touched on: pulmonary edema, right ventricular failure, arrhythmias, and remember MONA.
Awesome, and I think again we haven't teed up a witty sign-off.
We have, but it's a bit rude.
Yeah, no, well we're not doing that one. So I guess thanks for listening, guys. And if you're sweating, listening to this podcast, then you need to get yourself an ECG.